Good morning, and thank you very much to the session chairs for the opportunity to present today. It's certainly a pleasure and a privilege to be here. So I thought that the title of this talk was fantastic, kind of providing the guardrails or contraindications to minimally invasive liver resection. And these are my disclosures, which are not relevant to my talk today. So I think as a group, we can all recognize that minimally invasive liver resection has increasingly become the standard of care. Obviously, there are advantages to open liver resection: decreased blood loss, decreased postoperative pain and wound infection, and clearly there is a benefit to length of stay. And we know that the oncologic outcomes are comparable to open liver resection. So we've moved into a phase now where we're attempting to push the envelope as to what we can do from minimally invasive liver resection. But how do we know if it's too much to consider doing minimally invasive? And so I guess I would say in terms of contraindications, it's all relative. And so I would ask instead that we say, instead of contraindications, we focus more on what are the considerations for this operation. And so I've kind of broken this down into a few different areas that I think that we need to consider. So the first would be patient factors, next surgeon factors, and then obviously there are characteristics of the tumor or the lesion that we're going to be resecting. Certainly there are considerations for personnel and equipment as well. So first, I would look back on this paper. This was a paper that was published in 2013, so a little less than 10 years old now, and this was actually looking at laparoscopic liver resection at the end of the second decade. And really what they discussed in this paper were relative and absolute contraindications. And when I look at this paper now, many of the things that they list as relative or absolute contraindications, I think, have gone by the wayside. You know, when we think about gallbladder carcinomas or hilar cholangiocarcinomas, I think that as a group and as a society, we've figured out now that those are not necessarily contraindications. People who've had previous abdominal surgery, maybe. You know, I think it depends obviously on what type of abdominal surgery they've had before and the extensiveness of intra-abdominal adhesions. And then the size of the lesion itself, obviously, I think we've moved away from this. You know, we used to kind of say a lesion over 5 or 6 centimeters was a cutoff. You probably should not be doing that type of an operation from a minimally invasive fashion. But honestly, if it's a 5 or 6 centimeter lesion far at the periphery, is it really going to make that much difference if it's an 8 centimeter lesion? So I think some of these things do still reign true. You know, obviously a tumor invading the blood vessels is something you would probably have to think twice about. But I think that things are changing, and I think our ability to do these types of cases is obviously changing. There's always going to be patient factors. There's always going to be patients who may have significant cardiopulmonary disease. They may not be able to tolerate pneumoperitoneum. You obviously will always have to consider that. High BMI? Well, maybe. I mean, if you think about it, a patient who has a high BMI doing a huge subcostal incision or a big Makuuchi incision, that's a very hard incision for a patient with a very thick abdominal wall to heal. I think, to be honest, even in patients who have a high BMI, we can do minimally invasive liver surgery. I think patients who are having a redo operation or a redo liver surgery, we've definitely seen successful patients who are coming back maybe for another wedge hepatectomy, something like that. Choosing your patient correctly, even if they've had previous liver surgery, I think is still a possibility. There are some things that I obviously would gain a lot more consideration to. Again, patients with advanced cirrhosis or significant portal hypertension, that might not be a case I would approach minimally invasive. You know, someone who is having a 2-staged operation or an ALPS procedures, I have seen certainly some fantastic videos of those performed in robotic or laparoscopic fashion, but I think that you know, there's definitely considerations to be given for those types of procedures. So what are the lesions most amenable to minimally invasive liver resection? Well, obviously solitary masses, again, we kind of tout less than 5 centimeters and located in favorable locations. So segments 2 and 3, segments 5 and 6. Previously we used to consider the posterior superior segments as being inaccessible for minimally invasive liver surgery. But certainly with the increasing use of robotics, these areas are definitely accessible, and I think are particularly still well suited for minimally invasive liver surgery. So what are the contraindicated lesions? Well, I think that this certainly depends. And again, giant malignant tumors, I can completely understand maybe not approaching that in a minimally invasive fashion. An interesting thing that kept coming up in the literature as I was preparing for this talk was talking about the size of available retrieval bags. Maybe that is something to think about if you don't have a bag large enough to get a lesion into, but I've certainly seen, squeezing a large right lobe into a fairly small bag as a possibility. Now, there are always going to be issues like space issues, working inside the abdominal cavity or distensibility of the abdominal cavity. I think that's something to think about. And then certainly a significant vascular invasion, or if there is a need for vascular reconstruction, I think any surgeon would look at that and think twice about performing that in a minimally invasive fashion. But there are things that are no longer contraindications. Concomitant hilar lymphadenectomy, previously maybe we used to think that that was a contraindication, but it's not. In fact, many of those procedures are very well suited for MIS surgery. Also, need for biliary reconstruction, again, definitely can now be done from an MIS fashion. So I think we've moved away from things that we used to think were not going to be amenable, and now are really, again, embracing different types of techniques. So what are the surgeon factors that could be considered contraindications? So obviously, inexperience with technique, a lack of available mentorship or support, certainly the surgeon's overall knowledge and comfort with an increased level of technical complexity. And then again, we used to tout that ergonomics was a really big deal. Surgeon fatigue in doing a 5-6 hour laparoscopic case could be very challenging. And a lot of this has been overcome with robotics, I think. Certainly the comfort of sitting in a neutral position at a console, I think many of these things have significantly improved. So when we're thinking specifically about what are the cases as a surgeon that you're going to choose, we're all familiar obviously with the Iwate criteria for determining the degree of difficulty of a minimally invasive liver surgery. And this is what we need to be thinking about. If you are someone who is falling into this realm of maybe you don't have a lot of experience with minimally invasive liver surgery, if it's a particularly complex case, you probably should not be going for the high risk or high difficulty type operations, at least not early on in your career. Once you gain that increasing experience and increasing comfort with being able to do these procedures, I think you can certainly push the envelope as long as you have appropriate support, appropriate planning, and discussions with your team ahead of time. But again, for surgeons, as we're progressing in our abilities and through our careers, need to think about where you are and starting off a case and choosing those cases appropriately. We've already heard that today, obviously. So in terms of personnel and equipment, again, things that kept coming up in the literature was the size of retrieval bags. I've not really experienced that as a hindrance to doing MIS liver surgery, but something I did see repeated. In several of the studies that were discussing surgeons in terms of how or what were their barriers to implementing MIS liver surgery, they discussed robotic staplers, or also whether or not there was a CUSA available to use with a robot. I think many of these things are just going to be only a matter of time. Many surgeons, if they're doing robotic assisted liver surgery, will have a bedside assistant, attempting to use a CUSA for them. But I think, again, we're limited right now based on the technology, and what we have right now is certainly not going to be where we will be in the future. So the last thing that I wanted to mention was cost. And should cost be a contraindication to MIS liver surgery? There are a whole bunch of different determinants of cost, and this was actually a fantastic paper by Dr. Buell's group looking at this. And really what I think that we should take away from this is that the cost associated with minimally invasive liver surgery is definitely offset by shorter hospital stay, fewer blood draws, perhaps a reduced ICU stay, all of these different determinants. And so increasingly what we have found is that even though there might be associated higher equipment-related costs for minimally invasive liver surgery, ultimately this is not going to be the driving factor. It's going to be the fact that our patients are getting better faster and getting out of the hospital faster. And so this has actually been overcome, and this was a paper by Juan Sarmiento's group, where they talked about how at the beginning of their time in implementing an MIS liver surgery, this is for right hepatectomies, their costs were higher, primarily related to the use of a significantly higher number of staplers and staple cartridges. And through coming up with a protocolized approach to how they did their right hepatectomies, they were able to significantly lower costs over time. Now, in this paper, I will comment that this was also kind of at the advent of ERAS procedures, and so there was a lot that was going on to help lower costs altogether, but I think it's definitely possible. There's definitely a lot of ways that we can employ to help lower costs. So as I wrap up here, I just wanted to show this graph. This was a paper from Tom Aloya from 2017, again, talking about indications and contraindications. And really what Tom did in this is he kind of framed it through the Institute of Medicine framework that talks about how we think about indications and contraindications from the approach of safety, effectiveness, providing patient-centered care that is both efficient, equitable, and timely. And so really what I take away from this is that contraindications for minimally invasive liver surgery, they do still exist. There are certainly factors that we have to consider, tumor factors, but as long as we can provide a safe operation that will treat the patient providing an oncologic treatment that would be the same as we do in open surgery, then really I think ultimately that's what it comes down to, making sure that operation, again, it provides the best possible care for our patient. So again, contraindications to minimally invasive liver surgery, I think in general, are all relative. We have to consider these factors, patient factors, surgeon factors, the liver lesion size, location, and vascular invasion, and obviously make sure that as the surgeon you have an appropriate team, appropriate equipment, and personnel to assist with your case. And then as a surgeon, in terms of pushing your abilities to do cases from an MIS fashion, make sure that you have the knowledge, comfort, and experience to be able to safely do these cases. So thank you very much for the opportunity to present today. I certainly appreciate it.